Hello and welcome to case number 6 of NeuroCase Forum. I am Dr. Gigy Kuruttukulam, interventional neurologist at Lakeshore Hospital, Kochi. In this episode, I would like to share the story of a 45-year-old male. He had recurrent episodes of right-sided weakness since 2004. All these episodes improved within a period of few hours with medical management. Altogether, he had 6 episodes in the last 10 years. On the day of present admission, he started having numbness of the right upper limb with very mild weakness which started from 6:30 am in the morning. On his way to the hospital at 11:30 am, he developed difficulty in speaking and mild worsening of the power of upper limb to the tune of 4/5 in the upper limb and 4+/5 in the lower limb. At the time of admission, his speech was slurred. CT scan showed multiple small infarcts in the left MCA territory. He was taken up for angiogram at 12:30. DSA showed normal left internal carotid artery origin. There is no stenosis. Intracranial angio shows total occlusion of the M1 segment of the left middle cerebral artery. The rotational angio shows that the M1 is totally cut off. However, in the capillogram phase, one could easily see the reformation of the middle cerebral artery branches through the cortical collaterals from the anterior cerebral artery. In this projection, the whole of MCA territory, except for a small area in the center, is totally perfused. It was tempting to do an intra-arterial TPA or attempt a solitaire clot retrieval, but since the patient's deficits were minimal, with very good collaterals, no attempt for recanalization was done, and since the patient presented after 6 hours, IV TPA also was not given. The patient was continued on aspirin and clopidogrel. In addition, anticoagulation also was started. Within 12 hours, the patient's clinical status improved, speech became almost normal. He has very mild weakness of the right upper limb. Otherwise, there is no significant neurological deficit. I feel diagnostic angiogram is very useful in taking a treatment decision in the setting of an acute stroke. It helps to assess 1. The exact vessel occlusion, 2. The degree of collateral supply into the occluded territory, 3. The perfusion in the occluded territory. Based on these 3 parameters, an appropriate treatment decision can be made based on a cerebral angiogram. I would like your opinion on a couple of issues related to this particular case. What is the etiology? Is it an intracranial atherosclerotic disease? Is it a dissection? Or is it an embolism from an unknown source? 2. What is the best treatment in this case in the acute stage? 3. How to prevent further episodes? 4. How to decide on the time of onset when there is progression of deficits? Like in this patient, he started having mild numbness of the right upper limb at 6:30 in the morning, and there was worsening of his speech and right upper limb power by around 11:30 in the afternoon. 5. Would you consider anticoagulation in this particular patient? If so, for how long? 6. Since the information about the vessel occlusion, collaterals and perfusion is obtained by a cerebral angiogram, shouldn't a cerebral angiogram be given more priority in decision making in acute stroke? Please share your comments and opinion regarding this case. Thank you.